Our next talk focuses on a key area, a subject vital to improving the goal of life for women in their midlife and beyond. The topic is current concepts on menopausal hormone therapy. May I please invite Dr. Deepthi. Dr. Deepthi is a consultant obstetrician, gynecologist, and laparoscopic surgeon at KJK Hospital, Trivandrum. Over to you, ma'am.
Thank you. Respected senior members of the profession, my dear colleagues, good morning to all. I have been asked to speak about the current concepts on menopausal hormone therapy. So, as you all know, menopause is a very difficult time for women, and listening to menopause, a talk on menopause is also very difficult because it's a very dry topic. I don't have any laparoscopic videos on menopause to show you. So I really hope to make this presentation as interesting as possible, at least in flashes. So we all know what to give for menopause. The only thing is there are lots of myths associated with menopause. We, even as doctors, we worry about giving hormones to women in their perimenopausal as well as postmenopausal period. And what I would like to address in this talk would be about these myths regarding menopause. Are we really should we be really fearful about giving hormones to the postmenopausal women? So it's mainly about when, how, and to whom we should give menopausal hormone therapy. So let me start by putting some beautiful faces on the screen and their ages, of course. So we can see that all these Bollywood beauties and the film stars, and there is also the Queen, coming at 75 years, also pretty. So we know that probably they all have Botox and maybe surgeries to help them to look like that. But every woman has a dream to remain beautiful through menopause, as in their own way. So how is it possible? So where is the elixir for this? From age immemorial, man has been after, even gods have been after the divine nectar that will provide the youth. So is menopausal hormone therapy an answer to all this? Age is inevitable, aging is optional. What I feel about aging is getting older should make one more alive, with more vitality, more interest, more intelligence, more grace, and more expansion. So what is more important is aging gracefully. Am I right? So we are all going to get our wrinkles, but to age gracefully means we ought to take that age in the best possible way. Now, what prevents us from doing that are the ovaries. So the hormones that are coming from the ovaries are very vital, and when they stop acting, sometimes women are unable to control their emotions. So what can we do for them? So aging gracefully is one thing, but trying to slow it down is another. So we have had a lot of introduction for menopausal hormone therapy. Let me go straight into the topic now. So if our MHT and HRT the same, actually there is a slight difference because menopausal hormone therapy is the hormone treatment primarily used to alleviate symptoms associated with a naturally timed menopause. So that would be hormones given to the perimenopausal and postmenopausal women. And when you replace the hormones for women with hormone insufficiency relative to their healthy counterparts, like in primary ovarian insufficiency, that is when you call it as hormone replacement therapy. Now, what is new in menopausal hormone therapy is, we all know about, when we think about menopausal hormone therapy, we are familiar with conjugated equine estrogen and medroxyprogesterone or acetate being given to women. Are we still continuing the same? No. There are regulatory approved formulations of estradiol particularly that has come up, along with various later generation progesterones and progestogens, as well as non-oral MHT preparations, which will help to minimize the side effects of MHT. So we are all worried about the side effects of MHT. That is the one thing that is preventing us from prescribing MHT. The first myth is menopause begins at or after 50 years. I'm sure that everyone knows that in Kerala, the average age of menopause is 49, but it can start earlier or later. Women in their mid-40s often enter perimenopause, which itself can last for 4 to 7 years, and symptoms can be there from perimenopausal period onwards. The second myth is MHT can be given only after menopause. Now, this is something that even I was worried. I was also thinking about giving MHT only in postmenopausal women. But that is not the case. MHT in healthy symptomatic women during a naturally timed menopause transition is actually associated with symptomatic benefits and lower risks. So if you start MHT early in the perimenopausal period itself, when they are symptomatic, they are going to benefit more with low side effects. And there are studies which show that it will even reduce long-term risk conditions such as risk to heart, osteoporosis, dementia, and colon cancer. The third myth is menopause is natural, so women should just put up with it. Is it so? It's not so. Although menopause can be natural for a large number of women, 70% of women do suffer from vasomotor symptoms, and which may be mild. But 25% of women have severe symptoms, and which affects their quality of life, and they definitely deserve some treatment for that. So I would even use the term menopause survivor as we use the term cancer survivor, because it's kind of a big deal for such women to overcome the symptoms of menopause. And we are just asking them to stay calm for something when the ovaries are acting or even not acting. The hormones from the ovaries are not coming, they're not able to control it. So the symptoms of menopause, mainly the vasomotor symptoms as well as the genitourinary syndrome of menopause, the vaginal dryness, the hot flashes, night sweats, sleep problems, weight gain, mood changes. There can also be brain fogging. All these symptoms can be very severe in 25% of women. And menopause hormone therapy particularly is very effective against the vasomotor symptoms and the genitourinary syndrome of menopause. MHT and bone health. In addition to the vasomotor symptoms, MHT particularly provides, there is definite evidence that MHT provides a lot of benefit for the bone health of women, because there is a meta-analysis of RCTs which says that 20 to 30% reduction is there in the risk of hip, vertebral and total fractures in women who are taking MHT, especially in women who have been given MHT before the age of 60 years. Although this benefit lasts only for the period of treatment. Once you stop the treatment, the benefit doesn't go on, but there is some attenuation of protection following cessation of MHT. But the good point is that there is no increased risk of rebound fractures on stopping MHT. So you can actually advise MHT for women at high risk of osteoporosis for a limited duration of time to prevent fractures in future. The next thing is MHT aggravates cardiovascular disease. This is one thing that has, again, limited prescription of MHT by doctors. However, the British Menopause Society debunks this myth, stating that MHT does not increase the risk of heart disease if initiated at the onset of menopause. In fact, there is a potential for protective effect if MHT is started within 10 years of menopause. So you start at the right time. The Women's Health Initiative study, WHI study, the legacy of WHI has raised a lot of concerns about breast cancer and CVD risk in women taking oral conjugated equine estrogen and medroxyprogesterone acetate. And this study was stopped in 2002 and has actually given a widespread, enmity among the doctors for prescribing MHT. So this was one study which was actually biased to a large extent, because on post-intervention analysis and a cumulative 18-year follow-up, it has become clear that the risks of hormone therapy are actually low for healthy women less than the age of 60 years or within 10 years from menopause, because most of the women included in the WHI study were older women with higher risks. And that too, the risks were short-lived. So when the study was prolonged and future analysis was made at 18 years, there was no definitive increase in risk even for coronary heart disease in women who were prescribed MHT. This is also in the subsequent randomized controlled trials that came, like the KEEPS trial and the ELITE trial. They also have continued to demonstrate a favorable safety profile of hormone therapy when started early in menopause. So again, MHT is definitely recommended, we all know, for cardiovascular disease protection in the context of primary ovarian insufficiency. So why don't we extrapolate it slightly more and give it for the perimenopausal women as well. Now the final word has come from Cochrane, where they have published the data of meta-analysis of randomized controlled trials in 2015. And the data says that at all ages, even for older women, more than 60 years of age and more than 10 years since menopause, hormone therapy neither actually has a benefit nor risk for such women when hormone therapy is given. Well, definitely there is a benefit against coronary, there is a protection for coronary heart disease in younger women when MHT is started at the right time. Give it for women at the onset of menopause if they are symptomatic. So for less than 60 years, less than 10 years since menopause, we can see that they have a favorable profile. And also the total mortality rate, when we consider, actually was less for women who used before the age of 60 years or within 10 years of menopause, although there was an increased risk of venous thromboembolism. It's sort of like we have to balance the risk and the benefit for each woman. What about stroke and MHT? The 2015 Cochrane review again described no increased risk of ischemic stroke when hormone therapy was initiated less than 60 years of age and within 10 years of menopause. The next myth is about MHT increases blood clot risk and venous thromboembolism. Yes, MHT does increase the risk of venous thromboembolism. We all know that oral MHT, especially when you give estrogen alone or estrogen with progestogen, they are exposed to a 2 to 4-fold increased risk of venous thromboembolism compared to non-users. So this is one thing that is limiting us from prescribing MHT. But let me tell you, pregnancy increases the risk of DVT by 4 to 5-fold and postpartum by 12 to 35-fold. Does that make any woman decide that they will not get pregnant? No. We all get pregnant. We also have a postpartum period when we are exposed to such a high risk. But still, we are not prescribing MHT because it doubles the risk of venous thromboembolism, because we think that it might double the risk of venous thromboembolism. But again, when we choose the right kind of MHT for such women, especially those women at high risk of venous thromboembolism, we can actually choose a transdermal estrogen preparation or estradiol containing MHT in the place of conjugated equine estrogen. Because conjugated equine estrogen containing MHT carries the highest risk of venous thromboembolism. Again, progesterone also, the androgenic progesterone and medroxyprogesterone acetate has a slightly higher risk as compared to micronized progesterone, and intrauterine progestogen systems also have a very low risk of causing venous thromboembolism. So we can always think about giving him a transdermal estrogen along with an intrauterine progestogen for protection for the uterus. So transdermal estrogen, micronized progesterone and levonorgestrel intrauterine systems do not appear to increase the venous thromboembolism risk. As I already said, it's a first-line treatment for symptoms causally linked with menopause, like causally linked with menopause, like vasomotor symptoms and the genitourinary syndrome. Estrogen therapy in regulator-approved MHT doses considerably lowers the risk of hip, vertebral and other fractures in women with normal bone density, osteopenia and osteoporosis, and improves the bone density. Also, cardiovascular protection is given in healthy, younger and midlife women. Now, then, MHT is also protective for type 2 diabetes. So this was also new knowledge for me, because oral and transdermal estrogen use have both shown to lower blood glucose and improve insulin sensitivity, while oral estrogen has a stronger effect. So hormone therapy reduces the risk of type 2 diabetes, lowers fasting blood glucose and HbA1c levels, and improves insulin sensitivity. So there are so many societies which actually have provided guidelines which are supporting the use of MHT within 10 years of menopause and under the age of 60 years, and for women without contraindication. So you choose your patient rightly. Next important thing is about cancer. We are all worried about MHT causing breast cancer, MHT causing endometrial cancer. So the latest research shows that estrogen-only MHT may be suitable only if a woman had hysterectomy. So if she has no uterus, you can always go for an estrogen-only MHT, and it does not increase the risk of breast cancer above the woman's own lifetime risk. A combined MHT of estrogen and progesterone, the most common type of MHT, is definitely associated with a slight increased incidence of breast cancer above own risk. But again, if we consider the excess breast cancer cases per 1,000 women over 5 years, if you take in the women who are given MHT from the age group 50 to 59 years, actually estrogen only MHT has a protective effect, as you can see here. Again, combined MHT causes 8 additional cases only per 1,000 women, which is actually not a big number. Taking alcohol 2 to 4 drinks per day will also cause 8 additional cases, if you note that. Taking 4 drinks per day will increase the number to 11 per 1,000 women in the next 5 years. So, if you say that women in Kerala don't drink, we have other reasons also for breast cancer. So, there are additional 24 cases in women who are overweight, and we have many overweight and obese women in Kerala. So, BMI equal to or greater than 30 causes 24 additional cases, whereas an MHT being given at the right time just causes 8 additional cases. And 7 fewer cases in women who take at least 2.5 hours moderate exercise per week. So, exercising and lifestyle modification itself can bring down their risk of breast cancer. So, the benefits of MHT often outweighs the risk, but an individual assessment is essential. And when we consider the risk of breast cancer, there are other factors on which the woman can herself work upon, like being overweight, lack of exercise, and alcohol consumption, which can actually bring down her risk of breast cancer. So, and another advantage is that if you stop MHT, the additional risk drops. So, the risk decreases after stopping MHT. Again, breast cancer risk varies upon the hormone type of MHT being used. If it's a high-risk woman, if you think, conjugated equine estrogen with methoxyprogesterone acetate increases the risk of breast cancer, but has not been found to increase the breast cancer mortality. In contrast, if it is just oral conjugated equine estrogen alone, it actually reduces the risk of breast cancer and breast cancer mortality. What about endometrial cancer? Now, we have 3 types of MHTs that can be given. There is continuous cyclic MHT, where you give daily dose of estrogen followed by 12 days of at least progesterone per month. Or you have continuous combined, where you give daily dose of estrogen and progesterone. Or the third kind is also there, where you call it as intermittent cyclic MHT, where you give daily dose of estrogen and you give 3 days progesterone, then 3 days off progesterone, again 3 days progesterone, like in a cyclic way. So, in all these 3 things, they have the advantage and disadvantage. The maximum protection for uterus is definitely from the continuous combined MHT, where you give daily estrogen and progesterone. But that carries a higher risk for the breast. So, you have to again choose. Whereas, if you consider the sequential MHT, that carries a better profile for the breast, but uterine malignancies, there's a slightly increased incidence. So, again, a systematic review of 28 studies, definitely unopposed estrogen should never be given for women with uterus, because it causes an increased risk of endometrial cancer with persistence of risk for more than 10 years. When you give MHT for women with uterus, unscheduled bleeding is one of the side effects of MHT, which is more with sequential MHT as compared to combined MHT. Then micronized progesterone, when it is used, it has a favorable profile on VTE, stroke and breast cancer risk profile, but it has a slightly increased risk of endometrial cancer. So what I would like to say is that MHT, when we prescribe, it should be an individualized approach for symptomatic perimenopausal and postmenopausal women, and you should have a periodic re-evaluation, and the MHT should be chosen at the appropriate type, dose, formulation, route of administration to meet the treatment goals for the duration needed. So as I can see that the side effects of MHT depends on the age of initiation, the type of MHT, the route of administration, the dose of MHT, the duration of MHT, the time since menopause onset, as well as the type of progesterone used. So to choose the right MHT, it should be a shared decision making. You start with a low dose, you up titrate for symptoms and down titrate for side effects to find the ideal dose for each patient. How long? There is no arbitrary limit for MHT use. It's again a shared decision making. You stop when you find there is an increased risk of breast cancer or endometrial cancer, or if there are any adverse vascular events. So I always thought that old age is always 15 years older than I am. I think many of us will agree with that. When we reach that age, we think that we are not old. Again, when you consider the alternative to old age, I think old age is so bad when you consider the other alternative. So we can definitely be justified in giving MHT. And there is, as someone said, if I had known I was going to live this long, I'd have taken better care of myself. So with all this, I think we should change our outlook towards menopause. Probably we can change it to men, oh men, pause and take a look. We are going to give the right MHT to the right women at the right time, for the right duration, at the right dose, so that they can bounce back with increased vigor and vitality. Thank you so much.
Thank you, Dr. Deepthi, for shedding light on a phase often overlooked but deeply significant in a woman's health journey.